Thank you very much for the kind invitation and the nice introduction. And I want to discuss with you some approaches what we are currently doing in the treatment of hematological malignancies. Can I get the first? Yeah. So, okay, this is my former hospital in Tübingen. This is my disclosure. So when we look at the function of T cells, to understand how CAR T cells work, it's very important how it works. We have a peptide which fits into the HLA grooves, and this recognizes the T cell receptor, is recognized by the T cell receptor of the T cells. And if a T cells recognizes the target here, in this case the peptide, it will start to proliferate and fight against this target cell. So with CAR T cells, it's very similar. That's why it's called chimeric antigen receptor. So the T cells, this method was already established many years ago, and then for some reason it has been forgotten over the time. This was by Professor Eschar, and as you can see, what is a chimeric receptor? This is exactly we use a single chain fragment from an antibody directed against the target and fuse it with a chain of the epsilon chain from the T cell receptor complex. This is a completely artificial construct, and this is transduced into a T cell, and these T cells then function like a conventional T cells. It sees its target, and then once it sees its target, it's activated and starts to proliferate. This is how we produce these vectors. You need this, of course, the DNA sequences of your single fragments, the CD19, you need a hinge, you need these co-stimulatory molecules, the CD3 zeta chain from the T cell receptor. You pack it into a packaging cells, and this packaging cells makes a lentiviral product, a virus. And with this virus, you can transduce the T cells, and then the genetic information of the virus is transduced to the DNA of the CAR T cells, and the CAR T cells are expressing this to their surface, and then they have this artificial receptor on their surface, and this is how it looks like almost like an antibody molecule. This is the T cell with this artificial receptor, and this is the target, in this case CD19 or any other targets which you want to have. Of course, there have been a lot of developments over the time. This was the first generation by Professor Selig Eschar with the CD3 zeta chain, and then there were different co-stimulatory molecules. It has been shown this is important, and now this is the third generation, mainly has two co-stimulatory molecules, the CD28 and 41BB, which causes a good signal transduction into the T cell inside to cause the proliferation and stimulation of the T cells. We have now also the so-called drugs, the fourth generation of CARs. What they do, they have a payload of cytokines, and when they see their target, like here, they start to secrete these cytokines also to cause an inflammatory local better response to keep the T cells activated. And this is what we see when the CAR T cells see their target. They start to expand very rapidly, and this causes also some side effects like the cytokine release syndrome. It has been shown that you have to do pre-treatment of the patients with a conditioning regimen, a low-dose fludarabine cyclophosphamide, to make the patient lymphopenic. And then if these T cells come in, they come into a milieu where the body wants to replenish the T cells which have been made lymphopenic here, so they stimulate better. So without the pre-treatment with this, I think the CAR T cell will not work very well or not as good as we see it. It's very similar to the physiologic T cell expansion, that the T cells start to expand. And of course, this is a difference. Here we have some regulatory controls that every T cell response is dampened in a normal, which is sometimes not the case in the CAR T cells when you have this overwhelming cytokine release. And the first patient was treated in about 11 years ago. That caused a lot of publicity, of course. This was a patient, 5 years, did not respond to any chemotherapy, and she was the first patient who received that CAR T cells. That has been all published. She was very sick. She was on the ICU. That was the first patient who received tocilizumab for the cytokine release syndrome, but she made it through, and she's now a medical student at the job. And this was then the start of the multi-center Iliana study in pediatrics up to 25 years, which is still the indication for the Novartis drug, the Kymriah. And you can see here the updated results. This is the duration of remission and the overall event-free survival. And you have to keep in mind, these were all patients who had no other chance to get cured because they failed to respond to any known chemotherapy at that time. So it's quite, I think, a good success. But we have also seen there are problems with this CD19 drug, CD19 CARs, and you can see here one of the problems is relapse. About half of the patients still relapse after the CAR T cells. This is also in the Iliana trial, and these are real-world data, so not from the company, but this is the company trial, but these are real-world data from various countries. And you see here is this the CD19 positive relapse, but what's also a problem to some extent is CD19 negative relapses, and this is something we have to keep in mind, that might happen because the leukemic cells are very smart. They just lose their antigen and get invisible for the CAR T cells if you use only one target, and I will come to this. You see here that were in this trial 8 patients. This was 12% in this patient, and we see more and more of these CD19 negative relapses, and I think you use Kymriah in this country, and I think you also see this kind of relapses in these patients. So this causes a problem, and whether we need to do transplant later, this is still out of, I think, that we can give final answers whether we have to transplant these patients later after they reach remission or not. This is the FDA-approved products now. Of course, this is the CD19 directed ones, and there are also 2 now for the multiple myeloma in adults. I think the Carvykti is the latest one, which has also resulted in very good results in adult patients. It's interesting also that Kymriah was first used in pediatric patients. That's very unusual that you use a new drug and first try it in pediatric patients before going to adults, but for these CAR T cells it was the case. So it also works that if there is a new drug, pediatric patients might also be a target to it because they also want to live with their, of course. So why is it so expensive? You know, the Kymriah is in the range of $400,000 to $500,000 one manufacturing, and this is how they produce it. You take the lymphocytes, you take the T cell stimulation, then this is the viral transduction. The cells are then expanded in vitro to high numbers, and with the company-based methods, at least at former times, we had to cryopreserve the cells and then ship them to the company to somewhere in the US or where there was a production center. They were thawed, made all this process, and then they came also cryopreserved back to the hospital and were infused. So 2 times cryopreservation. I think everybody who works with cells knows this is maybe cryopreservation is not the best way to keep cells very good in function and alive. And you need specialized clean rooms, of course, for the isolation, transduction, expansion, and so on. And our target was to address also this CD19 negative problems. And this has been also discussed in nice reviews, why there is CD19 negative relapses. There might be genetic mutations in the leukemic cells that can be very fast, that the cells just stop to express. There might be a lineage change sometimes, so that the cells do not express the CD19 on a clonal level anymore, or there might be epitope masking. So there are various reasons why the CAR T cell mechanism might fail. There have been several solutions. One is co-administration. This has been done mainly by Chinese colleagues at the Children's Hospital in Shanghai, recently published in Journal of Oncology. Also very good results. They produce CD19 CARs and separately CD22 CARs. The other vector, which is what? Just a second. This was. Can we go back? Can I? Yeah, I think that was the wrong button. Sorry for that. Okay, so that was, so they use 2 CARs, and then we have also the B-cistronic, where we put 2 vectors in the same T cells, or a co-transduction, where we have randomly assigned the one or other or both, or a tandem vector, where these constructs are aligned, like shown here for CD19 and CD22. And we have used this tandem vector, CD19-22, and asked the question, is it possible to make these CARs locally in the hospital to save time also for the patient? Sometimes these patients have progressive disease. You don't have time for 8 weeks turnaround time, and the patient is chemorefractory and progressive. We know these patients. And we have also tried to do this in a online or on-site manufacturing using this automated device where all these GMP facilities are in the machine. This is a closed system. We do the cell isolation. We use CD4, CD8 pre-selection. Then the cells are transduced. They are expanded here. They are washed. And then it takes about 6 to 8 days nowadays. Before we took 12 days, but nowadays it has been seen and shown that the shorter the incubation time, even the more active the cells are. So I think 6 to 8 days is nowadays probably the time, around time. And more importantly, we use it fresh. So we take the lymphocytes, the lymphoapheresis from the patient directly to the machine. There is no freezing step. We take it out here, and then they go directly to the patient after all the quality assurance protocols, like, of course, sterility, endotoxin test. We check for the CAR T cell, transduction efficiency, and so on. So this works quite okay. And we have done this in Germany in my hospital, and you see not only children, but there were also adult patients. This was 6 autologous, 3 pseudo-allogeneic, and 1 allogeneic CAR T cell donor. Pseudo-allogeneic means that the patient already received a transplant, and the lymphocytes were after transplant, but of course they were from the donor originally, because the patient was engrafted with the donor cells, and 1 complete allogeneic donor who had donated the cells directly for after transplantation. So not from the patient, but from the donor directly. This is the input cells. Here we still had the 12 days, up to 12 days, but this is now changed to 8 days. The number of cells is always very high, more than we can use. We give about 3 million per kg body weight, and the transduction efficiency is also very good, in the range of about 50%, which is, I think, a good thing. These patients all had very refractory pre-B ALL, 2 adults, 2 adolescents, 2 children, and this is the number of cells they received. And 6 patients went into complete remission, also very advanced patient. These were the autologous patients. These were the pseudo-allogeneic, and you can see here these 2 adult patients. This patient already had 2 allotransplants and had a relapse after 2 allotransplants, and still went into remission, and he's still alive as we speak, with this pseudo-allogeneic from the second donor, of course. And then we have this patient also, who also had a relapse after allotransplant and received CAR, so there is still a chance. And I want to show you a little bit this patient who was completely refractory after allogeneic transplantation. And she's the patient then who received completely allogeneic CARs. So they have not been from the patient, but directly from the donor. When we received the stem cell product from the donor, we put part of the mobilized stem cells apart and produced the CAR T cells because we knew that this patient will need it, and I show you a little bit why. This was a patient, 17-year-old, with a lot of extramedullary disease. She had a lot of toxicity after conventional therapy, refractory disease. She had then autologous CD19/22 CARs twice, no effect, short response, but then also progression again. Then she received multiple chemotherapies, and then we did a matched unrelated transplant with a T-cell depleted graft without immunosuppression. We do alpha-beta depletion, and she still had a lot of disease. Normally, we wouldn't transplant such a patient while not in remission, but we knew we can maybe give her the CARs afterwards. That's why we prepared her from the beginning, and then she received these allogeneic donor CARs, and this is the patient, as you can see here. This is 4 weeks after MUD transplant. This is a PET MRI. This is still a lot of disease. After transplant, this is normally a death sentence for many patients. 8 weeks, it even progressed 8 weeks after transplant, so she got more. And this is not only here, but she had it all over the body. And then we gave her the donor CAR T cells, and this is 4 weeks after donor CAR T cells. They expanded. She had a slight graft versus host disease, grade 1 skin only, but no severe cytokine release, and now she's more than 3 years in remission as we speak. So that was quite successful, and this were her CAR expansion. As you can see here, she had quite a nice expansion and of both of the CARs, and that's maybe what keeps her in remission. She has 0 B cells, even now after 3 years, no B cells at all, 0. So she needs IVIG. So we made her a B cell immunodeficiency now, but that was the price for keeping her alive and fighting the disease. So what new CAR models are out there in the future? One is this adapter CAR approach, which we are now currently working very intensively. I have shown you this conventional CAR where this construct recognizes the target, but what we do here, we put in an adapter in between. So this CAR recognizes not a target on the T cell, on the B cell, or on the malignant cell, but it recognizes an adapter, and this adapter is labeled to an antibody via a linker, as you can see here. And this is shown a little bit better. And this adapter works quite nice, as you can see here. It works in very low concentrations. This is against CD19, so we just use an antibody like the anti-CD19 antibody, or here we use rituximab, labeled to biotin. This is the adapter. So a biotin-related antibody is enough to then have this antibiotin CAR. So this CAR is not recognizing anything. The physiological biotin is not recognized. The biotin is unphysiological, which we label the antibody with. And then this CAR is only activated if it meets the biotin-related antibody. And it's, as you can see here, it's very effective, even at very low concentrations. And it also works, interestingly, also with antibody fragments. So you don't need the whole antibody. You can use FAB2 fragments or FAB fragments. As long as they have the adapter, the CAR T cells are activated. And this is important later, how you choose your therapy, because if you want to have a long or short half-life of this adapter, and this depends also whether you want to switch off the CAR reaction, because if you withhold and I show you some data later, if you withhold the adapter, the CARs do not recognize anything. So it's also better manageable in terms of side effects. If you have a severe side effect, like a cytokine release syndrome, you just withhold the adapter, and then the CARs are blind. They don't see anything. This works in vivo in the mouse system, as you can see here. We used here the rituximab labeled to biotin. This is a normal anti-CD20 CARs, which we produced also as a comparison. So this is the conventional CAR, and this is the adapter CAR with the rituximab. And you can see both are very effective in keeping this lymphoma away in this mouse system with anti-CD20 adapters. Now for AML, I think, and AML is the biggest problem in CAR T-cell therapy, and also for adults. There are many more patients with AML than with ALL, and especially for elderly patients who cannot tolerate a transplant with AML. This might be an approach which we are now looking, and this, 5 minutes? And this group of Munich also used this adaptive approach. They use Fab fragments against different targets, as you can see here. On the AML cells, CD120, 123, 33, and CL1, and depends a little bit on the patient, which targets are expressed on the patient, so you can have somehow an individualized therapy, and it works quite nice in the also in the mouse system, as you can see here. This is the CD33 CAR, and this is the CD3 adapter CAR with the FAB fragment against CD33, so it works in this system. But we can also have several targets at the same time, because we can target 3 targets or even more at the same time with this approach, and we only need 1 CAR, but you have several targets at the same time, and we have done this. And this is our PDX model obtained from a patient, AML blast directly injected into this NSG mice. And you can see here, if we only use one of this adapter molecule against CD33, the mouse progresses. If we use only the one with 38 progression, also the 371, if we combine them all 3 together from the beginning, we can eradicate the leukemia in the mouse. So this is, I think, for the future that we target from the front line more targets to avoid this antigen escape, as what we see in the ALL, and this is the survival. These are the combined survival data from the mice, and this is very important, because when we look why do they escape, and we see those who are treated with CD33 adapter CARs and they progress, they lose their CD33. The same for this CD38, they lose it, and the same for the 371. But when we combine it, then the cells are killed and do not progress anymore. This has been shown recently also by another company or by a group in Dresden, where they use not biotin, they use a small peptide in this adapter molecule. So very similar approach. They call it also universal CAR, and they use this in a clinical trial in relapsed refractory AML. And this is they give the adapter molecule as a continuous infusion for 24 days, as you can see here, and this leads to the activation of the CAR. So they proliferate in vivo in these patients with refractory AML. And what's also interesting, they have seen even already in the low dose level, they have seen clinical responses. But most important for AML is that these patients recover their hematopoiesis when the adapter infusion is stopped. This problem in AML, CAR T-cell therapy, you might cause a completely eradication of the hematopoiesis if you use a myeloid target, as we did with our patient with CD19 B cells. So since three years, she has 0 B cells. You cannot live without hematopoiesis for 3 years if your CAR T cells persist. So you have to have a switch mechanism, and you just withhold the adapter, and then the hematopoiesis recovers. So I think this is something which we now also look into for the ALL, where we see the CD19 negative relapses. So we can combine maybe these 3 targets at the same time. We have antibodies against CD19, we have CD20 antibodies, even CD22. As long as we have biotin on these antibodies, the single adapter CAR is activated and would kill the blasts, and this is now what hopefully goes in early next year in the first clinical trials in AML. Yes, this is my last slide. So we not only can use this approach for targeting leukemic cells. We are also working on solid tumors. Here the problem is we have to have a stimulation so we can additionally link cytokines to these antibodies. So cytokine fusion proteins, like we use now one with IL-2 and IL-12 on the antibody. And as long as this antibody construct has the adapter, the biotin, the CAR T cells is activated. So we have a local inflammatory milieu at the tumor for these CAR T cells to come in, and we hope that we can use this, especially in solid tumors in the future. So this is my conclusion, that I think this is new models of targeting. We have to use this CD19 as an example that we have to avoid antigen escape. And we have also to have new methods like in AML where we can stop the CAR function maybe by this adapter. There are many other constructs out there, but I think here we only need one CAR and can be very flexible with the targets and maybe also adjust it a little bit to the antigen profile of the patient, especially in AML. Not every AML patient has the same antigen expression. With this, I thank you for your attention.